of this. And what we're going to be talking about is antibodies that block PD1 and PD-L1 and how the early data is leading to better treatments for patients. And the treatment melanoma is a push out of drug development where in a short period of time we've done science directly into patient benefit. And science is in two areas. The development of targeted therapies that are blocking genes or cancer genes that are telling the cell to be a cancer cell, and the development of immunotherapies that block that can attack these cancer cells directly. And the targeted therapies, which is not what we're going to be talking about today, is on the development of drugs that block mutually exclusive mutations in one pathway called the MAP kinase pathway that tells the cell to become a cancer cell. And there are mutations in BRAF, NRAS, or c-KIT in around 70% of patients, the majority being mutations in BRAF. And that can be specifically targeted by BRAF inhibitors like the FDA-approved Zelraf or the one in development, Brafenib, in particular when they're given together with MEK inhibitors. But for many years, that melanoma can be treated by turning an immune response to the cancer. And that response is made up of lymphocytes that are called T lymphocytes or T cells that have specific receptors that specifically recognize the cancer. And those cells, the important thing is how do we turn them on and keep them on so they can do their job. Well, the problem is that the cancer tries to hide from this immune system recognition and attack, and the cancer is not that different from our normal pigmented cells. So it's hard for the immune system to correctly recognize the cancer cell as the bad guy. We know occasionally patients with metastatic melanoma can have spontaneous responses or can have responses induced by vaccines. Those are very low frequency events that they are hard to demonstrate in studies. But we've got more reproducible benefit by giving cytokines that activate the immune system, like interleukin-2 and interferon alpha, and those cytokines are the that activate T lymphocytes, and those T lymphocytes then should go and attack the tumor. But the problem is that these cytokines have to be given at the highest tolerable doses, which give side effects, and also because the immune system has brakes that prevent overactivation. And one most best studied brake is called CTLA-4, which where an immune system cell is activated, then this brake tries to prevent from overactivation and attacking normal tissues. Blood antibodies to CTLA-4, in particular ipilimumab or Yervoy, have been developed over the last 10 years, and they give low frequency of tumor responses, but those tend to be extremely durable. Here we have the pivotal trials with the survival curves of patients who were on ipilimumab, which on top, and patients who were on control therapy, that is on the bottom. And there's a consistent separation of the curves throughout. It's a small difference between 20 and 10% throughout these curves, but it leads to these group of patients that have the majority of the benefit, around 10 to 15% of the patients who had a tumor response, and that tumor response is maintained many months later, and this follow-up is of 4 to 5 years. I'm following a patient for since 2001 who responded to ipilimumab, to Yervoy, and the patient continues to respond 11 years later. So we know that the power of the immune system is that it can give these very relevant responses in patients with metastatic melanoma that leads to durable benefit. What we really want is to be able to have patients who have normal lives after having had metastatic melanoma. It's clear, but it's with the tools that we've had so far, it's been limited the amount of patients that we could benefit. Now I go into a cartoon that depicts the immune system and how it's activated, and I'm putting this up so we can see the differences between blocking CTLA-4 and blocking PD-1 and the significance of both of them. And the whole story starts in a lymph node where there's an antigen-presenting cell called the dendritic cell that presents tumor antigens to the immune system cell, the T lymphocyte. The antigen-presenting cell would be like general to the immune system, and the cell is the army. And that army then expands, goes around the body, and tries to see a cell that has the same antigen that it was trained for. And this training here in the lymph node is like licensing this lymphocyte or T cell to become a killer cell and go around the body. So in a way, it's like giving weapons to James Bond and tell, when you see somebody who has this antigen, you just kill it. Well, our immune system doesn't like to have too many James Bonds going around our body and has developed a whole bunch of breaks. And the activation step requires two signals. First signal, that is the antigen, which is very specific. Each lymphocyte or T cell recognizes one antigen, giving its very fine specificity. But it needs a second signal called co-stimulation that is usually recognized by a positive receptor called CD28. CTLA-4 has been developed by nature to prevent overactivation to self-antigens, and it becomes dominant whenever the immune system tries to be activated against an antigen that it's growing from inside, like would be a melanoma antigen. So the of CTLA-4 blocking antibodies, both ipilimumab and tremelimumab, was that if we block the negative signaling, then the positive signaling prevails, and then we have an activated immune system, and then the cell can go around the body and can try to attack its target. Since this is such an early event, then the lymphocytes that are being activated are not specific for the cancer. They can be lymphocytes to anything. So that leads to the side effects of CTLA-4 blocking antibodies of Yervoy, where by releasing this early break, then we can have autoimmune toxicities like colitis or hypophysitis or thyroiditis, a whole bunch of inflammatory processes that are induced by the T cells being activated, not being the ones specific for the tumor. But even if this works, the immune system has developed means to turn itself off, and the cancer takes advantage of them. Here, the interaction between the cell that was licensed here and now is activated, and everything has worked well, and then it recognizes its antigen. So here we have the recognition, but it's being turned off by the tumor expressing a ligand called PD death ligand 1. And that again has a receptor called PD1 or PD1 receptor. This is a mechanism that our body has developed to prevent overactivation of inflammatory processes, where this ligand, PD1 ligand, is expressed after some tissues have inflammation. Well, melanoma tries to outsmart the immune system by hiding from it and expressing the same ligand, knowing that the immune system cells have the receptor for it. So the idea is that we block the PD1 either at the receptor or at the ligand, which I haven't depicted here. Then we can have this T cell that was already to kill this tumor cell, then be able to kill it because now we took away what allowed the tumor cell to hide from the immune system. We know that this is important because of studies done by multiple groups, including the group from Yale and Johns Hopkins with Liping Chen, Suzanne Topalian, and Drew Pardol, where they have been studying the expression of this ligand called B7H1 or PD1 ligand. And when they look for the expression of the ligand, you see that it is the same place as where the immune system cells are, which doesn't make that much sense. Why would the ligand be expressed where the tumor is? And then is because of process works. When an immune system cell that recognizes a specific melanoma antigen gets to the tumor, the system cell then starts making proteins that are trying to kill this melanoma cell. In them, it makes interferons. And interferons are recognized by the cancer cell, and then the expression of an anti-inflammatory process, which is the PD1 ligand. That ligand engages what's been turned on by the recognition of the T cell receptor, which is the PD1 receptor. And this negative interaction is turning off this lymphocyte. So we started with a lymphocyte that recognized the right antigen, produced the right proteins, but that triggered a feedback loop that turns itself off. What we want to do is to block it, to turn off this negative feedback loop, either with antibodies to PD1 or PD-L1, and they'll lead to improved responses to melanoma. And now we have a series of antibodies that are being developed, both to the receptor and the ligand. We still don't know what is best, is to block the receptor, block the ligand, and we'll know in the near future. But it's good that we have all of these drug development, because it's becoming, it's allowing a more rapid benefit to patients by having more competition. The leading antibodies are the antibodies from Bristol Myers, either to the receptor, which was called MDX1106 and now has the generic name of nivolumab, or the one that it's against the ligand, MDX1105. Data with these antibodies has been published already in the journal in medicine called the New England Journal of Medicine, led by the group at Johns Hopkins. They published a study with the PD1 antibody and the PD-L1 antibody. Both showed responses in patients with melanoma. Here we have a big lesion that becomes smaller, a patient who develops skin pigmentation because of the activation of the immune system against pigmented cells. Here we have another patient with metastases that is responding to blocking the ligand. It not only works in melanoma, it also works in patients with kidney cancer and very interestingly in patients with lung cancer, somewhere where there didn't used to be any immunotherapy that had any evidence of benefit. The data is very striking. These are graphs that start from 0, which is the starting point of the size. And if they go down, that's a response. If they go up, that's progression. And these in 2 doses, separated by 1 log, at 1 milligram per kilogram or 10 milligram per kilogram. We can see that it looks more or less the same. There's some patients progressing and some patients responding. And some patients responding where it's a stable disease for a long period of time, or regression, which is regressing for a long period of time. This is really a big step forward. We tried to make a plot like this with Yervoy or tremelimumab, the 2-CTLA-4 blocking antibodies. We would have a lot more patients progressing and very few, less responding. Effects. The common side effects, the only one that's notable is fatigue. Around 1/3 of patients. It can become serious. That's the grading here of 2 patients out of 100 who had fatigue that was important enough that they had to, it limited their activity. Those are the common side effects that can be noted. Sometimes they can be rash, and sometimes they can be diarrhea or itching. The side effect is pneumonitis or inflammation of the lung, where in patients with melanoma, in this series didn't lead to a serious adverse event, but it did induce toxic deaths in 3 patients with other cancers, with lung cancer and kidney cancer. With lung cancer, it's probably because of the birth of the lung in a patient who lung cancer may be limited by prior toxic exposures and by surgeries, that they would be less able to cope with an inflammation on the lung. But the practical point is that if you any patient who's on PD1 antibodies, they should seek medical attention if there's a development of cough. Now we're going to talk about another one from which we're seeing more and more data, MK3475, which is a PD1 antibody from Merck. And that's something where we just reported data with Omid Hamid, who's a colleague of mine from the Angeles Clinic here at UCLA, Los Angeles, and a group of investigators from UCF, from from Boston, from many places, New York, Australia, and us at UCLA. And this study reported a striking response rate in patients with metastatic melanoma. Here we have a group of 39 patients that were treated in the phase 1 trial at 2 doses of this PD1 antibody. The response rate was 47% by a set of criteria called the Ribas criteria, which is very stringent criteria where to call responder there have to be 2 sets of scans that have a shrinkage of the tumor of 30% of all year in the maximum diameter, which if we turn it into volume, it's an over 50% of shrinkage of the initial tumors. It happened in half of the patients. That compares favorably to any other immunotherapy that we had tested in patients with this disease. Patients who were naive to prior ipilimumab, the response rate is a little bit higher. Well, it's a couple of points higher. And in the 10 patients who had previously received ipilimumab, there were 4 patients with an objective response. So that's a 40% response rate. It's probably too early to call, but it's telling us that this works in all patients in half of the patients more approximately, and it can work in patients who have previously progressed to ipilimumab. This graph depicts the duration of these responses, and this is in weeks. And I'm sorry, it didn't have it doesn't say here, but that's weeks. Each one of these would be a month. So we can see that the majority of patients had been followed for 1, 2, 3, 4, 5, 6, or 7 months. And if patients have these little rows here and here and here, that means that they continue to respond, suggesting that the great majority of patients who had an initial response continue with response for all of these months. We still haven't followed up the patients long enough. We want to follow them further, and probably by this year's major oncology meeting, which is called the ASCO meeting in early June, we'll have a better picture of how durable these responses are and how what is the response rate in these patients. I just want to give you some examples of some of our patients. Here's a patient who has all of these being large lung metastases and this being liquid in the lung. The normal lung is this black part, and the heart, which is displaced by all of this big mass. Well, just with several months later, we can barely see anything residual. All of this is the heart and the heart vessels, so all of this is normal. And the liquid has gone away. This is a patient who had progressed on biochemotherapy, high-dose interleukin-2 and ipilimumab, and had very low chances, but negative, and now is doing well, continues to respond, and went from requiring oxygen and being on a wheelchair to being able to go back to playing tennis. Here's the same patient with liver metastases. All of these dark brown are metastases in the liver, and you can see how they're responding after several months. I have a patient with a healing ulcer from a primary melanoma in the face, with something called the desmoplastic melanoma, also with lymph nodes and lung metastases. Here we can see a month later where the primary lesion that wasn't healing after radiation therapy, after surgery, and after receiving ipilimumab is now completely healed. The lymph node is gone, and the lung metastasis is also resolved. I could many other examples because here we're having a high frequency of these responses, and the key thing is going to be at what cost are we getting these responses and how durable are these responses, and this is data that will generate in the next several months. The side effects from these other PD1 antibody are similar to the one that we discussed before, nivolumab from Bristol Myers, with fatigue being a common side effect. Some patients develop cough, and that's what worries me if this cough goes on to having a pneumonitis. And the other side effects may be thyroid problems. We usually monitor the thyroid hormones to see if they go down. There was a patient, a 96-year-old patient, who died with a myocardial infarction while was being treated for pneumonitis. So probably the pneumonitis had something to do with the development of the myocardial infarction, and that's why I'm stressing so much that if there's cough, patients should seek medical attention. So I'm reaching the conclusions of this seminar, and what I wanted to convey to you is that antibodies that block PD1 and PL1, I'm convinced that with this early data is already telling us that they are going to give a new benchmark on what we consider immunotherapies for melanoma. The durable response rates are beyond what we saw before with interleukin-2 or Yervoy, and they're clearly beyond 10%. That's what interleukin-2 or Yervoy gives, probably beyond 30%, which is what the early data with nivolumab suggested, and maybe higher with a Merck antibody. But those are different studies, very early, not that many patients, so they're not directly comparable. But it's suggesting that there's lower toxicities compared to CTLA-4 blocking antibodies and to interleukin-2. Is going to be, are these responses as durable as the responses with ipilimumab? So they are established, do they last for years? We don't know what's the right dose. We don't know what's the right frequency. We don't know how many doses we should give. Right now we're continuing therapy. We will not know when to stop. But all of these data that we need to be generating. We're worried about the development of pneumonitis, and that can put patients into big problems. So if there's cough, they should seek medical attention. And then something about ligand. So we talked about how this works. And it works when the ligand is in the tumor. So develop a diagnostic test that says this is the right patient to get one of these drugs because it has the ligand, and this is the patient who is not going to respond because it doesn't have the ligand. We still do not have a good test for this, and the reason is more technical. Is about the specificity of the antibodies to detect and how do you draw a line on what's positive and what's negative. But there's multiple companies that are working on this, and I think that's going to also help us advance this field. So I'm happy to take any questions. I'll get it back to Catherine.
Okay. Thank you very much, Tony. It's a great show, and I'm sorry to everybody that had difficulty hearing. We had a little bit of a technical problem, which happens with these things. So let me get on with your mentions that came into Melanoma International about this. Everybody seemed very excited about this webinar. So the first question was about the design of the BMS phase 3 trials. I don't believe they've opened yet, but the big question is why they're allowing any crossover if people should progress, and why they're using dacarbazine and other old therapies as the randomization. Do you have any idea why that design is in place?
So my understanding is that trial is going to be open in patients who have previously received ipilimumab and have progressed after that. The risk that we do not have a standard of care in that situation, and patients who are BRAF mutant obviously would have the option of getting BRAF inhibitors, but patients who have progressed on BRAF inhibitors and have progressed on Yervoy, we're left with a series of options that none of them have improved survival in any randomized trial. It's obvious that with this data that PD1 antibodies would be high in the list of things to be trying, but that's to be demonstrated to the satisfaction of the regulatory bodies. The goal of the drug development is to develop agents to a place where they're available to everyone. And the problem is that at one point in this drug development, they're only available in clinical trials, and sometimes the clinical trials are randomized clinical trials. Different. The stringency of drug development requires that things are demonstrated to improve the lives of patients. And the way to do that is by having a comparator arm. That leads to getting drugs available for everyone. And that's the ultimate goal. So Bruce Snyder has designed a clinical trial that's a very clean clinical trial of where half of the patients receive the PD1 antibody nivolumab, and the other patients receive what would be a standard of care, which would be chemotherapy in patients who have progressed on Yervoy and progressed on Zelboraf or whatever else they have received before. If they're looking for an overall survival benefit, then if control arm, the patients on chemotherapy are allowed to get the PD1 antibody, then that would not fit the goals of looking for overall survival. At all of these, the study design from Merck is a little bit different, and that's a study that's going to be open pretty soon. I think at UCLA will have it open very soon, where patients who have pressed on ipilimumab, on Yervoy, and if they're BRAF mutant, they have progressed on Zelboraf, take the same design of randomized trial where half of the patients get the Merck 1 MK3475, and the half receive chemotherapy, the carbazine, Taxol, or carbotaxol, I think it is. But the patients in the control arm are allowed to cross over if they have progression. Mm-hmm. The rationale there is that they're not only looking for overall survival benefit, but also the period of time that patients are responding to the first therapy. The assumption being that there's going to be more patients responding to the PD1 antibody and responding longer. So that allows to give the patients in the chemotherapy control the ability to then get the PD1 antibody.
Right. Yes, we just did those Merck trials. We did get a list of them. We don't have the international ones yet, but we'll put them up as soon as we get them. And same with the BMS trials. They'll be on our forum as soon as we get the list. My other question is, why do you do a biopsy for both of these trials? I guess people need to have some sort of palpable tumor that you can get to that biopsy prior to getting the PD1. Is that correct?
So all of this is also to develop better therapies and to tailor them better to patients. It's very important to have two pieces of information to understand when it works and when it doesn't. One of them is to have baseline tissue, and that's in these studies. It can be archival tissue, a biopsy that was done in the past, or a new biopsy that's done on study. And the idea is going to be: is it true that the presence of the PD1 ligand in the tumor is what predicts a response or not? That's a very important question for the future, not for the patients who are being treated now, because if we knew that was a perfect match, then we would only be treating the patients who have the ligand. But we still don't know, and we still don't know how much expression does need to be there, how much ligand, PD1 ligand, needs to be there to benefit from these therapies. The other important piece of information is that it works by having the immune system inside the tumor and attacking the tumor. If we do a biopsy where the patient is getting these therapies and there's no immune system activity in the tumor compared to the baseline, then it's unlikely that that patient is going to benefit, because it's not the antibody that's killing the cancer, it's the immune system that's killing the cancer. If the immune system is not there, then it didn't work. But what immune system makes it there and the cancer doesn't die? Well, there has to be something else. So that's why there's so much stress in getting biopsies on study. In my experience has been that the patients understand this. They understand that we're doing a therapy to benefit them, but also they're contributing to benefit to the future generations of patients. And they've been very eager to be able to go through these biopsies both in peripheral lesions or CT-guided biopsies or deeper lesions, which put them at risk for complications. But they're still doing it because in many cases I hear patients where they come and say, I want to help you to develop better treatments for these patients, or for patients with the same disease.
Wow. That's interesting. I didn't understand that, the biopsy reading, but that makes a lot of sense. Because that is more of a systemic, not as, specific to a tumor response. But there any blood marker, correct, of like
Not
LDH?
so far. No. So LDH is a non-specific marker of tumor growth. It also can be elevated when there's inflammation. So that's why sometimes it's difficult to interpret LDH with PD1 antibodies. I've seen level increases of LDH in many patients early on after they're getting the treatment. That may be because the immune system is inflamed, or because the immune system is attacking the tumor, releasing LDH, or because the tumor is progressing, and that's hard to tell. There's a lag of time between attacking melanoma with the immune system and getting a response in the tumor. That's why most of the endpoints are delayed on assessing responses to PD1 antibodies.
And it does stay in the body for a very long time as well after you have finished infusions. Is that correct?
Yes. The antibodies are wonders of nature. They're developed by our evolution to protein that can stay circulating in the body for a long time. These antibodies are made to mimic the natural antibodies that our body makes, and they stay around for a long time.
Great. We've talked about the BMS and the Merck. I just wondered if there was anything out there about some of the others coming on the scene. There was one that came on very early by CureTech, and yet we've not heard much about that since. Has there been any further analysis of that PD1 agent?
We were not part of that of those studies, and I haven't seen it reported, so I don't know results from it other than indirectly. I hope we'll see some in the next several months in the oncology meetings. I haven't heard results from Genentech, who has a PD1 ligand antibody in the clinic, or from Amplimmune, GSK, and then MedImmune, all of them having antibodies that are either in the clinic or ready to start in the clinic. We'll have to wait a little bit longer to see any data from them.
ASCO we'll hear about more. Okay. It goes in June for anybody.
Yes.
First of June. What longest term response we know about for PD1?
So the Bristol Myers experience started 4 years ago, mostly in Johns Hopkins and Yale. I heard Suzanne Topalian say that there's been some patients that were treated 4 years ago that continue with a response. Those are the patients on the first in human trial of nivolumab. I haven't seen reported the frequency of these and what has happened to them, were there patients who were continuously treated or they stopped at some time. So we'll need to know more about this.
I have one patient who she's years and 8 months out, and she's coming up on her third, and she wants to know she was on the BMS study, phase 1, and she wants to know whether she should continue with booster infusions to prevent recurrence, or should she just off the drug?
And that's a question I cannot answer. I would suggest to seek the advice of the physicians. They'll have more information about this. It's a hard decision to make for the first patients, and we'll have to learn from what's happening.
It seemed logical if it does stay in your body for a long time that perhaps you wouldn't, need to continue on it. But I guess we shall see. I mean, I know these questions are coming up with, the BRAF drugs as well, whether to, if somebody's NED and they've been on it for 2 years, do they dare go off or continue?
Yep.
So I'm glad to have all these options, though, to be questioning all these things. I love hearing about long-term responses. So would you say that 30% is about the accurate rate of response for PD1?
So the longest, the most patient treated and longest experience is with the BMS PD1, and there it seems to be quite solid around the 30% response rate. So that's what I usually quote. With the early data with the Merck antibody, I said, well, maybe there's possibility of being a little bit higher, but we have to know more.
Okay. Do you think approval will be, and I'm sure it's something you're not sure of, but do you think it'll be fast-tracked by the FDA once they get this data?
Yeah. So the fact would be that the patients have been treated with a particular condition so a particular situation, let's say ipilimumab refractory, and then you get the same group patients with a group of patients that have been treated similarly, and there's a response rate that's beyond what we would expect with anything else. That could be grounds for approval, although it's very hard to get approval with that. Usually the regulators ask for a randomized trial where half of the patients have received the drug or not. So if we have to wait for the results of the randomized trials, we're looking at 2 years from now. If it can be approved to basis on patients who had previously received ipilimumab and are now responding to PD1, then it could be a little bit shorter.
And use is probably not in the picture.
Well, compassionate use
expanded use, I mean.
Expanded use programs should be open once the data has been generated and being reviewed by the FDA, but we already know that the data is positive.
Mm-hmm.
If it's open before, it makes it hard for future patients to get access to these drugs because it's delaying doing the definitive trials.
Mm-hmm.
It's not something that I decided. It's something that society decided. So we put these very stringent regulations with the FDA and even more in Europe and in Australia, where the benefit has to be demonstrated in randomized trials. And if you have compassionate use open, then who would go on a randomized trial? How can I sit in front of a patient and say, oh, we have two ways of getting this drug. One, everybody gets it. One, only half of the patients get it. Which one do you go on to? Well, I put all of my patients on ones where everybody gets it. So it's an ethical dilemma that we have as a field and as doctors as treating melanoma oncologists.
Yeah, but I'm wondering, so what triggered when your went to, or IPI, went to expanded use before approval? The data was in, and it was just the decision was made after the data was phase 3 was in.
Yervoy had 2 expanded use programs, one in 2008, 3 years before they had data, and another one in 2010 when they already had the data. Mm-hmm. In 2008, had to be closed several months later because it was unsustainable. It wasn't generating data to help the approval of Yervoy. But also it had another side effect, which was it precluded having clean data for the other antibody, tremelimumab, because of patients in the control arm on the random trial of tremelimumab received Yervoy. And that defies the purpose of all of these. I think that's something completely wrong. If we do a randomized trial and then we sabotage it by giving the patients in one arm, some of them get access to the other drug, they shouldn't be doing randomized trials.
Right. And the anti-PL drugs, we don't hear a lot about those. Are those kind of on the back burner, or?
I don't think so at all. The BMS report on PD1 antibody and PD-L1 antibody, it suggests that the PD-L1 antibody may have a bit less response rate, but it also is better tolerated.
Wow.
So maybe if we can select the patients based on the ligand, then we would have an excellent drug. Also, it could be better in combination with other agents, and we're seeing how hard it is to combine immunotherapies with other therapies.
To combine them, because that's the next question. Why is it hard to combine the other drugs?
Well, some drugs may be counteractive, in particular chemotherapy. So the chemotherapy kills dividing cells. If we're activating the immune system, divide and attack the tumor, then the chemotherapy may be killing some cells that we're activating with the PD-1 antibodies or with CTLA-4 blocking antibodies. If we're starting to do immunotherapy approaches and we're taking a break for the immune system, an early break like CTLA-4, a late break like PD-1, then we get cytokine, we get at least the immune system, and our body doesn't really like that. It leads to a whole bunch of side effects. So we have to be careful about how far we go with these combinations, and how they obviously have to be tested very carefully.
So you're like IPI and PD1 together, then danger effects, or?
Well, I don't know. The clinical trial ongoing, for what I know, in Memorial Sloan Kettering and Yale, and we're very early await results of that study. I hope that they're very careful investigators that only will do things that are safe in patients.
Okay, and then the BRAF drugs combined with with the PD1.
Already a clinical trial ongoing with that. There's a clinical trial from Genentech giving their PD-1 antibody with vemurafenib. So that's another study that we're going to be watching very closely. Right.
So that shouldn't be as I would think as dangerous as a normal chemo in combination.
I think it had a scientific rationale for combination where one drug can help the other, as opposed to one drug can hurt the activity of the other.
Right. Okay. I'm at the end of our list from our patients, and I, again, can't thank you enough. I'm sorry we had some difficulties with this program. We'll have it all figured, and I'm sure that we're going to have a really well part of it up on the website soon. So thank you so much, Tony, for your time and your wonderful slideshow.
Thank you, Catherine. Thank you, everyone who called.